So Dr. Rose has done a wonderful job of giving us the view from 30,000 feet. Now we're going to come down to about 5,000 feet for a closer view, a more drilled down view of thyroid autoimmunity. And then the remainder of the conference will give you more of a up-close and personal view of very specific topics that affect every one of you in this room with Graves' disease or another version of thyroid autoimmunity. So as Dr. Rose has just informed us, there are multiple types of autoimmunity. The two most common forms of thyroid autoimmunity are Hashimoto's thyroiditis, which we've heard a little bit about, and Graves' disease. Now many of my colleagues speak of these two processes as entirely separate and distinct. I think of them more as polar points in a spectrum where there are common molecular and cellular events which cause both of them. And that it is merely the idiosyncratic, that is the personalized characteristics of immunity in the individual that determines whether one gets Graves' disease or Hashimoto's thyroiditis. They're very different in their clinical presentation for the most part. Hashimoto's thyroiditis commonly presents as the most common form of hypothyroidism, that is to say, individuals who manifest too little thyroid hormone production. And the constellation of clinical signs and the symptoms are quite distinct. And often the thyroid gland enlarges or remains of a normal size, but almost always feels irregular and abnormal to the fingers of a trained thyroid palpator, that is an endocrinologist who is particularly skilled at distinguishing normal from abnormal thyroid. And because the thyroid eventually fails in many patients with Hashimoto's thyroiditis, especially if they live decades with all of the pathology that is undoubtedly occurring in the thyroid, they will require thyroid hormone replacement. And this is a relatively simple matter. Dr. Yannikakis tomorrow, I believe, will be discussing in great detail how we typically manage Hashimoto's thyroiditis and the consequent hypothyroid state. Now, Hashimoto's thyroiditis shares relatively infrequently a particular manifestation which is peculiar to thyroid autoimmunity, that being the ophthalmopathy or the eye disease, which we more commonly see in Graves' disease. Now, when I say thyroid ophthalmopathy or Graves' orbitopathy, these are just different terms for the same condition. And so I know that can be a bit confusing, and there is an effort afoot to standardize the nomenclature, the terminology we apply to this condition. But it's peculiar to individuals with one or the other forms of thyroid autoimmunity. Now, Graves' disease typically presents to a practitioner's office with thyroid overactivity. Now, again, a small portion of these individuals with bona fide Graves' disease have absolutely normal thyroid function. That is to say that their thyroids produce just the right amount of thyroid hormone. And if one were to follow these individuals over the course of years, decades, a few percent of these folks will never, ever manifest any abnormalities in their thyroid function. And if they're questioned, they will endorse feeling absolutely normal with regard to their metabolism and all the symptomatology, which I'll review for you in a few minutes. So it's quite peculiar, these diseases that we lump together, probably out of our own ignorance. As Dr. Rose has admitted in mixed company, we know precious little about these diseases, and I share his embarrassment as I reach the age of dotage, and as I see youngins whom I've been lucky enough to interact with to help train take my place, thinking that how precious little progress we've made. But there is an upside to that gloomy scenario. That is to say that the emerging generation is smarter and better equipped to explore the unknown of these diseases. So as Dr. Rose stated so eloquently, Graves' disease is an autoimmune disease. In the case of Graves' disease, what's targeted? Well, we know about the thyroid, and we're going to discuss that in a moment, but the other tissues which are infrequently but sometimes involved includes the tissues around the eye. So when we say thyroid eye disease or Graves' eye disease, that's a misnomer, because the eye itself is not primarily a target for Hashimoto's or Graves' disease. Rather, it's the tissues surrounding the eye which become embarrassed. And what occurs is a very specific and, as far as we know, unique set of events which lead to what we call tissue remodeling. So it's just like you've got an old house and you want to improve it, so you call in the carpenters and the plumbers and the painters and the designer and then you get the bill and you're quite upset if you're the husband. And I speak from experience. And what happens is the orbit gets remodeled in a way that is not reminiscent processes anywhere else in the human body. Then there's a relatively rare process that typically involves the skin in the lower leg, or what we call the pretibium, and this is called dermopathy. And only about 1% of individuals who develop the eye disease develop dermopathy. Virtually no one who doesn't develop clinically important eye disease will ever manifest the skin process. So I just wanted to take a little excursion here and remind you of the very beginnings of recognizing Graves' disease as a clinical entity. And there are three big names associated with this disease. Caleb Perry, who probably was the very first individual to recognize, and certainly the first to take pen to paper and describe it in the medical literature. And the initial report in 1825, but he probably got the wrong end of the stick because he thought it was fundamentally a heart problem. Then there's Robert Graves, who actually was in my medical school class in 1812 or so, you know. I am pretty well preserved. Anyway, Bobby, as we used to call him, actually was a really shrewd guy who loved to get credit for all of his ideas and his contributions, and we generally refer to this disease as Graves' disease, at least in this country. But in Europe, when you say Graves' disease, people look at you kind of funny, and they don't know what you're talking about, and they say, "Oh, you mean von Besedow's disease," and that's Carl Adolf von Besedow, and he, like the other two individuals, really made seminal, pioneering observations. So Perry was a friend of a famous guy called Edward Jenner, whom you've probably heard. This is not the great Olympian athlete Bruce, who I think is on some sort of reality show now. Is that right? With a really bad facelift. Dr. Douglas, are you responsible for that? I hope not. It's not a great advertisement. Anyway, he lived in England, and as I just said, thought that Graves' disease was actually heart disease and caused rapid heartbeat and heart pain, what we call angina. And then Graves, of course, who was really a magnificent intellectual giant who essentially put the Dublin Medical School on the map. And then von Besedow, and I think the reason why we don't call this disease by his name is that he probably hired the wrong PR firm. I don't know much about advertising and PR in the early 19th century, but I suppose he made some injudicious decisions. So this is actually a Venn diagram which I throw up here to suggest to you that there's a remarkable overlap in those with Graves' disease with regard to thyroid overactivity, eye disease, and dermopathy, the skin condition. Now, what I am implying here is that if you have Graves' disease, you probably have some evidence of all three of these components of Graves' disease. It's just that the majority of patients with Graves' disease are relatively lucky in that the eye disease and the skin disease are so minimal, so minor that the patient and his or her physician are unaware of their presence. But it is said by those brighter than I that should one take the time and the effort to biopsy the tissues involved, that is the connective tissue around the eye and the skin of the lower leg, and subject those tissues to examination, one will find evidence for this disease. So what, for instance, does the dermopathy look like? Well, this is the plaque form of dermopathy. The important thing about dermopathy is that it has cosmetic consequences. It doesn't look pretty, and many of my patients who have significant amounts of dermopathy spend time trying to camouflage it. There are examples where dermopathy becomes a real medical problem because it constrains the blood flow to the lower leg, and then we do certain therapeutic maneuvers to try and control the process. But again, what I want you to get out of the slide is that there are three components. You can see this patient of mine from many years ago who actually had to undergo a process where because he was getting exposed, his eyelids wouldn't close, so the eyelids had to be approximated together just to provide him with relief from all that exposure. So why are thyroid and orbit and skin targeted in Graves' disease? One of the key points I want you to get out of this talk is that Graves' disease is a systemic disease. We believe it's a bone marrow disease. It affects probably every tissue in the body. Having said that, the localized manifestations in the thyroid, in the connective tissue around the eye, in the leg skin, we believe result from the unique attributes of the tissues that manifest this disease. We've spent the last 20 plus years trying to understand what is unique about those tissues. And in so doing, that is, if we can define more precisely why those tissues differ, why they're susceptible to the systemic disease, we think that we can develop therapeutic strategies for interrupting the disease. As Dr. Rose mentioned, these white cells called lymphocytes, or B and T cells, infiltrate both the thyroid and the orbit in Graves' disease. Now, These are data from Dr. Douglas's studies in the lab, and all I want to do is to show you that if you study these cells, you can identify very specific differences between these cells coming from patients with Graves' disease and those who are healthy. And we believe that these characteristics of cells from our patients with Graves' disease really hold the key to developing strategies for controlling the disease better than we currently can. So we heard about autoantigens a moment ago, and these are nothing more than proteins and rarely carbohydrates or even fat molecules that are complexed to other molecules that are misrecognized by the immune system as foreign when in fact they're part of self. Now, there are a small group of these so-called autoantigens that seem to be in play currently with regard to importance in causing the disease. And everyone's favorite, of course, is the TSH receptor, which everyone thought was expressed only on the surface of the thyroid cell, and which is involved in regulating hormone production and release, that is, thyroid hormone production and release from the thyroid gland. Then there's the IGF-1 receptor, which other investigators and we have focused on for the last 10, 12 years. And then another molecule, which you may or may not have heard of previously, called thyroglobulin. Now, thyroglobulin is merely the precursor molecule of thyroid hormone. So it's the big daddy or big mama molecule in the thyroid gland that gets chopped up into thyroid hormone. You've heard terms like T4, T3. Well, they come from thyroglobulin. So just a few words about the normal physiology of the thyroid and how it gets regulated in health. So at the base of the brain are structures called the hypothalamus and the pituitary. And then, of course, is the thyroid gland, which is in the anterior neck. And what happens is that a molecule called TRH stimulates the pituitary to synthesize and release TSH. TSH in turn stimulates the thyroid gland to organify iodine, to put these iodine atoms on thyroglobulin, and to process thyroglobulin and make T4 and T3. Now, how is this process controlled? Well, nature was quite clever, and what has happened is the thyroid hormones, T4 and T3, in circulation feed back a negative signal to the pituitary to stop making TSH, stop releasing TSH. And therein is struck a harmonious balance between the need for thyroid hormone and not getting too much or too little thyroid hormone. Now, what happens in Graves' disease is that antibodies that mimic TSH fool the thyroid gland into producing thyroid hormone even when there's already plenty. And so what they do is they shut off the hypothalamic pituitary axis, and there is no feedback inhibition, and the thyroid goes nuts. And it just continues to make and release thyroid hormone. And this thyroid hormone then has all sorts of metabolic consequences in virtually every tissue in the body, the heart, the lungs, the brain, the kidney, the liver, you name it, the muscle. So this is a really a complex set of circumstances where there's an intersection between an immune system which has gone wild and a thyroid which has gone wild. So one can see then that the manifestations, those things that lead to the symptoms that you feel and the physical signs that your doctor documents when you go in and see him or her in the disease. So immunity and excess thyroid hormone. And one of the more difficult tasks in trying to unravel the complexities of this disease has to do with understanding which symptoms and signs come from too much thyroid hormone and those that come from immunity gone wild. And this is just a schematic of what goes on within the thyroid, the importation of iodine, its addition to thyroglobulin, the making of T4 and T3, and its release. So how do we make the diagnosis of Graves' disease? Well, I like to delve into the history the patient comes in with before I begin to examine him or her. And one of the aspects I'm very interested in is the family history. As Dr. Rose has told us, Graves' disease, like many other autoimmune diseases, travels in families. And it's quite likely that an individual with Graves' disease will have a close relative with either Graves' disease or Hashimoto's thyroiditis or type 1 diabetes or Crohn's disease, which is an inflammatory bowel disease, or multiple sclerosis, one of the other forms of autoimmunity. And what this really tells us is that there must be common elements of cause that underlie many of these diseases. And we believe that that's really that's the gold vein in the mine. Because if we can identify not necessarily those elements which are peculiar to Graves' disease, but those which are shared with other forms of autoimmunity, then we can have what I like to call the aha moment, where we can effectively alter the course of many of these diseases. So, common complaints of patients coming into my office with Graves' disease. My thyroid is enlarged, I'm more nervous than usual, my heart pounds, it's racing, a symptom called palpitation. I've lost weight without trying. My eyes are more prominent than usual. Now, this is often first appreciated not necessarily by the patient or the patient's intimate family, but by individuals who see the patient only periodically, so that the changes in appearance become much more noticeable if you're not witnessing as a daily phenomenon the individual, and because day-to-day variations are so subtle. But if you haven't seen Aunt Rose for 6 months and she's really started changing her facial appearance, then that might become very noticeable to you. And then almost uniformly, patients with thyroid autoimmunity tell me that they fatigue much more easily. They're tired. They're spent. And many attribute it to just growing old or to some of life's other challenges. So one of the things I want you to appreciate is that many of these symptoms, many of these complaints that we hear are quite nonspecific. That is to say, they could be attributed very easily to other things going on in our patients' lives. And it's only the aggregate of the symptoms and what we find on our physical examination that really make us suspect that we're dealing with Graves' disease. So again, the symptoms include fatigability. Many patients feel warm. Now, this is particularly a challenge to interpret for the patient and for the physician or the healthcare provider, because many women are in their 4th, 5th, 6th decade, and they're undergoing menopausal symptoms. So their thermoregulation is already abnormal, and it's new for them. And so being able to distinguish between those kinds of changes and the changes that we would attribute to Graves' disease can be challenging. I've mentioned weight loss. Now, the interesting thing about Graves' disease and weight is that if you're perfectly healthy otherwise and can keep up with your Graves' disease and eat more to meet the caloric requirements, then you can actually gain weight in this disease. So again, it's more of trying to identify changes in weight, changes in appetite that is more instructive to the clinician. Bowel habits often change so that you're pooping, maybe you're a 1-a-day pooper, and then all of a sudden you're pooping like crazy, and it goes on, for weeks or months. Well, that's something that needs to be investigated, and certainly in Graves' disease, this could be a symptom. If the thyroid gets too big, then you have problems swallowing, and this could be solids, like you're eating a big steak, or it could be liquids, but you're having trouble getting food and drink down behind that enlarged thyroid. Many of my patients, especially those who use their brains intensively in what they do for a living, or students, will say that they just can't pay attention, that their mind races and it wanders, and this is a manifestation of the intellectual toll that this disease takes. Reduced sex drive, this is pretty much uniform. And if we're talking about an individual, a woman in her reproductive years, then the duration and the quality of the menstrual period changes, frequently becomes scant, and frequently becomes less frequent. So menstrual irregularities are not uncommon. On physical exam, so what do we find as healthcare providers? Well, we often find subtle or not so subtle changes in the eye exam, and we'll hear a lot more about that in the next 2 days. The thyroid is often enlarged. There's often lymph node enlargement, and this is not dramatic lymph node enlargement like when you have a bad flu or something and you feel these knots in your neck. It's generally more subtle than that. When we listen to the heart, we notice that the heart is beating much more rapidly. There might be the development of abnormal sounds, which we call murmurs. This is caused by increased flow. The heart is working very hard in uncontrolled Graves' disease. The hyperthyroidism causes the heart not only to beat more rapidly, but also to increase the volume of blood that it's pumping through the body. The hair and the skin texture often change. There's pretibial dermopathy, which I just mentioned, and then a very, very, very rare condition which affects the nails. What other laboratory testing is useful in making the diagnosis? Well, sometimes we subject the patient to thyroid imaging, and we get what we call scans. So these are tests where we give tracer doses of radioactive iodine. These are minuscule doses that are probably below those associated with any kind of biological effect. And then we look at the imaging on an X-ray film. We can also use a modality called ultrasound, where sound waves are used to define the architecture of the thyroid. Now, your endocrinologist will use terms like scans and uptake, and you may well undergo these procedures. Scans, though, think of scans as helping define the architecture of the thyroid. Thyroid uptake, as defining the function, the activity level of the thyroid. So while one can get the necessary information by doing a combined scan and uptake, you should be aware of what each provides in terms of information about the thyroid. And here's just an example of a scan. This was an I-123 scan, and you could see both lobes of the thyroid. The thyroid looks like a butterfly, and I think you see on the logo of the foundation the butterfly, and it's an apt analogy. Thyroid function tests. So what blood tests do we get, and other determinations to see whether our thyroids are functioning normally? So there was a test that was very much in vogue many years ago, many decades ago, when, for instance, Dr. Wood was a young man. Yeah, during the First World War, I'd say. So the basal metabolic rate is actually a terrific determinant, and it's actually the information we want to have because it determines the biological impact of the amount of thyroid hormone that your thyroid gland is making. Unfortunately, it's a particularly difficult test to standardize. So if you, for instance, got a BMR analysis at, say, a crummy hospital like the Mass General in Boston, but then you went to a truly outstanding academic center, say, the University of Michigan or Johns Hopkins, or a place with reputation, then you might get an entirely different result. So we haven't quite figured out how to make this test more user-friendly. So what we do, instead of actually quantifying the amount of metabolic activity resulting from the thyroid hormone that we make, is we measure the levels of T4, which is kind of the parent hormone, or T3 in the bloodstream. And these actually suffice pretty well and are pretty good surrogates for thyroid hormone economy, both in healthy individuals and those with Graves' disease. Thyroglobulin is sometimes measured in Graves' disease. I don't really think it's particularly useful in that setting, but rather the antibodies against thyroglobulin, which are often, not invariably, but often positive, detectable in patients with Graves' disease, along with another kind of an autoantibody, the anti-TPO antibody. But the specific antibody, which is also an antibody causing the hyperthyroidism of Graves' disease, is known as thyroid stimulating immunoglobulin, or TSI. And the levels of that antibody are really useful in understanding where the individual is in terms of the immunologic impact on the thyroid gland. Now, the eye disease, which we're going to hear a whole lot more about from experts, occurs in anywhere from 10 to 40% of patients. That is clinically detectable eye disease, because I've already told you my bias that everyone with Graves' disease has at least subliminal thyroid eye disease. It's usually mild and usually does not require major intervention. Now, it's a process that is temporally linked to the onset of hyperthyroidism, but that linkage in terms of time is not precise, and it can manifest itself before the hyperthyroidism. It can manifest itself at the time of symptomatic hyperthyroidism, or it can manifest itself way in the future, 20 years, 30 years after the diagnosis of Graves' disease is made. So it's a very uncertain relationship that exists between the eye disease and the thyroid disease in Graves' disease. Now, this eye disease usually runs a course of being an active problem of 3 to 5 years. But this, too, is rather imprecise. But unlike most other forms of autoimmunity, it tends to burn itself out and become what we call a stable or chronic problem. That is to say, it's a problem that is not changing. So it's only the consequences of what occurred during the active phase of the disease, which, as I say, usually runs a 3 to 4 year course, sometimes shorter, sometimes longer. And as I want to emphasize to you, most frequently it can be managed by rather conservative measures. And this is actually the time course of typical Graves' ophthalmopathy, where this active disease, and you can see this young man has a lot of signs of congestion. His skin around the eye is red and angry. And here's the same individual during the stable phase. Now, you'll notice that he doesn't have very good alignment of his eyes. In fact, he's seeing double here. He was seeing a single image, normal imagery here, but here we call him entering the stable phase of the eye disease. And in this stage is typically where the ophthalmologist will consider surgical remediation of the problem. And just to remind you that the orbit, that is the space that holds the eye itself and the muscles that regulate its positioning, and the optic nerve are in a confined space. And what happens in ophthalmopathy is that this tissue expands, and we have some insight into why it expands, but the mechanical consequences of this expansion has to do with crowding, and the eye is then forced anteriorly, forward, and that causes the prominence of the eyes in Graves' disease. So this young woman has lots of signs of active disease. These are congestive features. Look at the eyelids themselves and how puffy they are. And then this is the individual with a stable disease, both before and after my surgical colleagues have done their magic. Now, most of the individuals, the vast majority, require only supportive help for their eye disease. And I recommend protecting the eyes from strong light. Even more importantly, I like my patients to protect themselves from the drying effects of wind, which can be very desiccating. So they're often on artificial tears. There are certain nighttime maneuvers to help protect the eye, especially when the eyelids don't close completely. If there is any misalignment and double vision, then a really nifty technique involves the use of prisms. Above all, the recommendation I make to my patients who continue to use tobacco is to cease and desist immediately. This is the one behavior that we can control, and in so doing, predictably make the course of the eye disease much less severe. I like for patients to avoid eye makeup, especially during the active phase, because as a group these are quite irritating. And I like for patients to wash their upper face with baby shampoo, which is actually quite soothing. Now, we have a limited repertoire of therapies that we can intervene during the acute phase of this disease, the inflammatory phase, the phase where active remodeling of the tissues occurs. And this is going to be covered in great detail. But suffice it to say, agents like high-dose steroids are often useful in limiting the inflammatory symptoms and signs of the disease. But unfortunately, we don't think that steroids or radiotherapy, which we'll also hear about, really change the natural course of the disease. So that we don't think that those with bad eye disease will wind up in any different place ultimately, whether they've had the steroids or the radiotherapy or not. But clearly, many believe that these agents, these techniques, are useful in abrogating the symptoms that occur during active disease. So there are many other agents that are either being looked at prospectively as potential therapies, and many of these include the drugs that we hear advertised on television for the treatment of rheumatoid arthritis and those kinds of diseases, psoriasis, another autoimmune disease. They're now being tried in Graves' disease, some with considerable promise. Again, we'll hear a lot more about that in the next couple of days. So my recommendations are certainly to stop smoking. I think that rest is very important, as is the avoidance of unnecessary stress, if there is such a thing. You need to take your medicines and take them as prescribed. A good diet is invaluable, and exercise sensibly. Many of the same recommendations I would give to my patients who don't have Graves' disease. So, what do you look for when you're trying to hook up with a healthcare provider to help you manage your Graves' disease? Well, what I think is an invaluable group of attributes which would include that the individual have a lot of experience with Graves' disease. I think that physicians and other practitioners who answer questions that you have do so with all necessary detail. That they consider all of the symptoms that the patient is experiencing, that they're responsive, that they don't insulate themselves from the patient, many because they're too busy, so it may not be through any fault of their own, that they're available for consultation, and that they really look at you as a whole person, not as an individual with just a thyroid problem. So, there's certainly a good and caring healthcare provider for every patient out there. Sometimes it has to do with the congruence of personality or style. But you need to find yourself being helped by an individual whom you trust and with whom you share a rapport and feel confidence in. So do you need an endocrinologist in this disease? Well, I mean, my response here could be punctuated with self-interest as a reflexive response. And I could say, yeah, certainly an endocrinologist. But I think there are good internists who have substantial experience with this disease, but they're few and far between, and probably getting involved with an endocrinologist, and even with someone who focuses on the thyroid. And there are many of us who limit our practice to thyroid disease. That's probably not an unwise direction to take. I think even more importantly that your healthcare provider sees herself or himself in the context of a functional team of experts that can provide the necessary support and counsel as you go through the disease and the therapies. So, and I think we at Michigan have adopted this strategy of a multi-component thyroid center, which Dr. Douglas actually heads up and initiated when we all moved from Los Angeles. And we think that we offer the patient a comprehensive set of care. So our team includes dietitians, a thyroid surgeon. So this is important that if you're going to have surgery on your thyroid, that it be performed by an individual who doesn't do thyroid surgery every few weeks or months, but someone who does thyroid surgery many, many times each week, because it's a technically challenging surgery. Nuclear medicine physicians are absolutely important for consultation and therapy. Ophthalmologists who focus on Graves' disease, a dermatologist if that's relevant, and if there are emotional issues, and I think that one of the other important components of this disease has to do with feeling unnatural for yourself in terms of being excitable or depressed or anxious. These are the natural consequences of what is such a broad assault on your body. Acknowledging that you need to speak to someone, or you may need some medication to make you feel better. So we always include in our discussions individuals who focus on mental health care. So that's the end of my talk, but I just want to now preview for you what we're going to hear in the next couple of days. You'll hear about how to manage hyperthyroidism and hypothyroidism, the medical and surgical treatment of the eye disease, future for treatment of the eye disease. I want you to take away from this talk a note of encouragement that we're beginning to understand Graves' disease far better than we've ever done, and that we believe that in the next few years we're going to be able to design very specific therapies which ultimately will target the thyroid and the orbit, the tissue around the eye, with therapies that will not remove the thyroid functionally or anatomically, but will re-educate the thyroid and the immune system so that it behaves normally. We think that that's possible. We think that that's within grasp. And the other thing I want to leave you with is this important realization that there's a whole array of healthcare providers out there who are experts at managing every aspect of Graves' disease. And what we're here to do at this meeting is to provide you with the armamentarium to seek out these individuals and to engage in an important relationship which results in effective care and return you to an absolutely healthy, normal state. And we expect only one thing from you during the next two and a half days, and that when you ask us questions, don't accept half answers. This is your opportunity to catch us without a ringing telephone in the background, without our pagers going off. So demand of us everything that you would like, because we should be seen as a resource for you. And just a very short rundown on who we're going to hear and what we're going to hear. So Dr. Warby from the University of Nevada, who's been a wonderful supporter of this foundation and has participated in many meetings well before those of us who are novices. We'll talk about building a support system. Dr. Ho from UCSD will talk about radioactive iodine ablation. Dr. Brumund from UCSD will talk to us about thyroid surgery. Dr. Kakawa from ophthalmology at UCSD will talk about a multidisciplinary thyroid eye center. Dr. Granite, also from UCSD, will talk about how we manage double vision and corrective therapies. Dr. Douglas from University of Michigan will talk about alternative therapies for the eye disease. And then tomorrow, Dr. Yannikakis from UCLA will provide us insights into how to manage hyperthyroidism with antithyroid drugs, and also how to take care of low thyroid, hypothyroidism. Dr. Wang from UCLA will talk about conservative care of the eye disease, and will, I think, give us a rundown on the options for surgical rehabilitation of the eye in Graves' disease. Dr. Cockerham will come down from Stanford and will tell us how to look and feel great. I hope that involves some more youthful appearances. I certainly could benefit from that kind of help. Dr. Gottschalk from UCSD will talk about pediatric Graves' disease. Dr. Lesser, who's a psychiatrist who had Graves' disease 25 years ago, will give us his personal journey as a healthcare provider, experiencing all the emotional and physical travail. And Dr. Wood from the Mass General will talk about family planning and Graves' disease. We're delighted that so many experts have agreed to share with us their gifts, and we're even more grateful to all of you for journeying from near and far and for making this what we hope is a truly meaningful experience. And I thank you very much for your attention. So yeah, that's a really insightful question. So it's at least two things. One, it's the accumulation of water in the orbit. So there's a big molecule called glycosaminoglycan, which loves water. And it accumulates in Graves' disease, curiously, and it traps the water. And when tissue traps water, it gets more voluminous, right? That's one component. Another component is that the eye muscle enlarges. That is, those muscles that control the position of the eye, they expand. And the third thing is that the fat around the eye expands. And we think that's because there are more fat cells in Graves' disease. And we think that all of these components are eminently targetable as therapy. That is, we think that we can block all elements of this tissue expansion without surgery. Certainly, there are decompressive techniques for surgically reducing what nature has done. All three. But we think that it might be possible to stop the disease in its tracks before all those things happen.
So
once they've happened, they're by and large irreversible. At least applying the biological principles that we have to work with today. That's right. There are wonderful surgical approaches which can help reduce the consequences of the disease. I believe that a realistic point of view is that one rarely achieves a pre-morbid state, that is, that it's absolutely as it was before the disease. But most individuals who undergo these kinds of surgical procedures are vastly improved and, in fact, are happy both in terms of function and appearance. So the end result is very satisfying for all involved. Yeah, I mean, I wish I could say that I had never heard that problem emerge. But unfortunately, and I think your situation speaks directly to the situation that we know exists. That is, many physicians are poorly prepared to recognize Graves' disease and its allies, and are not equipped to deal diagnostically and therapeutically with this disease. So what we need to do is, and you need to grab us, is to help you find the right individuals to help you. Because you live in the United States. Yes, there's little reason, in my view, just speaking off the cuff, for you not to have competent and comprehensive therapy.